So come on up, Roland. So Roland Fargo is the CEO of the Physician Organization for Adventist Southern California. He's a really wonderful guy. He actually came from physical therapy, so he's actually a clinician as well as an administrator. He went to the dark side. He can tell you that story. But he's really done a great job of changing a culture that was very hospital-centric and really trying to move them along this population health pathway. So I'll let Roland talk to you about what they're doing.
And before I do that, Esther is going to hand out a pop quiz to see if you actually can recall what Alan just told you. All right, we got a track there? Okay. So thanks, Alan. It's an honor for me to be here with you guys tonight. Looking forward to learning as much from you through this discussion as I share with you. It's an honor for me to be here with two experts as well. And what I'll say first and foremost is I am not an expert, and I'm not even going to attempt to play one tonight. I think what characterizes me in my role is that I'm comfortable failing, and I feel like if I fail fast enough and enough times, we're going to figure out what success is going to look like on the other side. And so that's been my approach to helping our organization transform. There's a few fundamental principles, I guess, that guide the way that I look at transforming our healthcare organization. And before I get into what are we doing as Adventist Health, I want to talk a little bit about why we do what we do. And so for me, first and foremost, as a part of a faith-based not-for-profit organization, we're very clear on what our mission is. And our mission is to serve an underserved community and provide health care to all community members. And I think why that's so important is healthcare is evolving tremendously right now. I see a lot of organizations that want to change their identity. They want to become someone different than who they've been. And I think that's a big mistake. And so for us, staying very clear as to who we are and how we continue to deliver services in the community is really important. The big transformation we're making there is moving from a federation of hospitals that was really good at providing excellent care to 10%. It's that group of community that's going to come within a given year to a hospital or access services supported by the hospital, to now saying we're going to take on the responsibility of keeping people healthy and well. And that brings a whole 90% of our community into focus, and we have no idea really how to appropriately respond to that. And so this is a time of a lot of trial and error. It's a time of research. It's a time of testing new models. It's a time of making a lot of mistakes. And what comes with that, just as Alan said earlier, is not a reduction in costs. Actually, it's an increase in cost for us right now. We're spending a lot on tuition, learning how to design the systems that work specifically for our local community. So staying true to who we are and mission is important. Really making sure that we're clear on what our community needs are is really important. And that's the second piece. And that guides then the vision of how we design the services that we create. There's a lot of differences, even in the markets I serve, between Simi Valley, Glendale, broader community in the San Fernando Valley, and downtown East Los Angeles. Some vast differences in what those community needs are, but there are some real commonalities when you go community to community that I continue to hear the same needs. First, access. You know, across the board, I look at patient satisfaction surveys, whether they're in my local markets, whether they're with our competitors, whether they're across our system or nationally, how we benchmark with others. We may score 92%, 94% on a patient liking the experience they had within our organization. Access traditionally is about 52%. How easily they can access a service in a timely manner and get the care that they need at that time is a huge issue, and so it's something that we're focusing on. So access is big. In addition to access, coordination of care. That's another area that we continually fail on. How well do we coordinate those services from one provider to the next? And the third is compliance. How easily do we make it for them to actually participate in their health care and follow the programs that we've provided? So that contextually guides how we develop our services. Adventist Health, again, was really a good federation of hospitals, I would say up to 2010, when I met Alan, and he did a lot of the dirty work to help us start to think differently about who we were going to be in the future as an integrated delivery system. And we moved from that hospital care to say, now we need to develop different types of people to serve the market. It's not just about the nurses in the hospital and the doctors, but now how do we relate to MAs and how do we relate to other non-licensed healthcare practitioners that can help us organize the way we deliver care in the community? And it's new to us to start to learn to work with different people who have different backgrounds. How do we develop the places then that can appropriately provide that effective service for the community? And it opened up a whole new area of developing clinics. We're looking at primary care clinics, specialty care clinics, urgent care clinics, and what role do each of those play in that network. We're also looking at some additional models that serve a specific need, like the federally qualified health centers. Most people understand an FQHC as probably what they would consider an over-subsidized primary care office. But the reality is it provides a very, very important need of expanded services to a community that is in significant need. It brings psych services, it brings dental services, in addition to the medical services to those communities. And so how do we effectively use those clinic opportunities in a community? And that's something we're working toward. We have about 20 different clinic networks now built. And the biggest challenge on a day-to-day basis for us is how do we staff each one to specifically meet the needs of those neighborhoods, organizing the work that the physicians are doing, the mid-levels are doing, and the staff are doing. We're still losing money on those networks. In addition to the staff and the people, and Joel's minions are now telling me that it's about 3 minutes that I've got left. That's how I interpreted the little minion, right? 3 minutes, that's minion language there. So past the people on the staff side, it's about giving opportunities to physicians to align with us and continue to serve the patients that they've been used to serving. As they transition, as networks start to develop and patients just don't have fee-for-service choice anymore of who they're going to see, and they now have to be a part of a defined network, how do the physicians stay attached to those patients? How do we organize that care? And so physicians are looking for models that keep them connected with their patients. And we're developing a number of different models that allow them to do that. One is, in California, we have the corporate practice of medicine that prohibits us from directly employing, but we use a foundation model to allow physicians a quasi-employment opportunity to continue to work with us in a network. There are those independent physicians who don't necessarily want to move into an alignment like that and really prize their independence. And how do we help them organize around independent models, like an IPA for HMO business? We have in Simi Valley, we're launching a clinically integrated network to focus on PPO and fee-for-service business, and evolving an ACO infrastructure that organizes groups of independent physicians to think about how they design a system that improves cost and delivers better value of care. So past the employment models and the independent models, working with the physicians and staffing, past the places, then we get into programs and services. Looking at how we develop centers of excellence. We're launching a limb preservation program that brings together a collection of different practitioners around one common disease process. How do you save somebody that's got advanced disease? How do you save their limb? And we bring infectious disease, podiatry, interventional cardiology and interventional radiology, vascular surgery, wound care, a number of people together to look at a patient from an interdisciplinary perspective and say, how do we provide the best care possible for that patient? So we're testing models like that as well. So there's a lot going on. I would just characterize it as a lot of failures with high costs that we're learning from, and every day we continue to refine the work we're doing and make it a little bit better, a little more cost effective, and provide a little higher quality care to our patients. And we'll talk more about that, I think, through our discussion on the panels. So I want to thank you, and I'll turn it back over to